Good evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra and Mr. Arvind Singh from Medical Services and Mr. Saurabh Sharma, Marketing Manager, NAARI Division, Jagsonpal, are delighted to welcome you all today to the academic session with esteemed experts and would like to express our gratitude for your presence today. Today's discussion are brought to you by NAARI Division of Jagsonpal Pharmaceuticals, makers of Yuliprist 5 mg tablet of Ulipristal Acetate and Fibristone 25 mg tablet contain Mifepristone. A warm and hearty welcome to esteemed experts and attendees. Dear attendees, we request you to post your questions, suggestions, clarifications by text in Q&A box. Please note this webinar is streaming live on Facebook and the link is already shared in the chat box. To refer this webinar recording in future, please visit our YouTube channel, Jagsonpal Medical Insights. As we initiate the today's sessions, we welcome Dr. Archana Basir. Dr. Archana Basir is consultant obstetrician and gynecologist, Director Akash Hospital, Indore. She is Guinness Book record holder for largest uterine tumor removal. She has held many prestigious office positions and is currently SAFOG Chair of Imaging Science and Committee and Fellow Representative AICC RCOG West Zone. She was Vice President FOGSI in 2020 and organized AICOG at Indore in 2021. We request Dr. Basir to kindly initiate the session.
Hi, good evening, everyone. Thank you, Dr. Amit Saxena, for kind introduction. And thanks to NAARI Division of Jagsonpal for organizing this meeting. Because, it is very important that we talk about medical management and other managements of fibroid, because the burden of fibroid is increasing. It's not that the fibroid is something which is new. Fibroids are known to be there in women's uterus since ages. But previously, women were not coming forward for management and treatment. And because of the increasing age or deferring the fertility also, initial days, the only option was just to remove the uterus when there is a fibroid and a menstrual irregularities. But now we have to offer the different options to women because their needs are different. Even in the presence of fibroid, you have to really try to conserve the uterus. And we have got now beautiful molecules for managing the medically fibroids. And we have very good speaker today, Dr. Ashish Kale, who will be enlightening us on both the molecules, Ulipristol and Mifepristone, their advantages and how really to use them and what is the benefit you get out of it by comparison in several studies. So I'm sure we are all looking forward to hear from Dr. Ashish Kale, and Dr. Girija Wagh is here as an expert commentator for giving us her inputs on how really in the clinical scenarios to manage with the availability of so many things in our armamentarium these days. So Dr. Ashish Kale, I invite you to present your talk on Ulipristol versus Mifepristone and role in management of fibroid. Dr. Ashish Kale is a very well-known gynecologist and he is based in Pune and he is director of Ashakiran Hospitals and Asha IVF Center, Pune. He's Secretary-elect Pune ONG Society. He's a good friend and a good human being, very approachable. And I've heard him, he's a very good speaker. So over to you, Dr. Ashish.
Thank you, madam. Thank you for your kind words. And at the outset, I'm really thankful to Jagsonpal team for this initiative, academic initiative. For as a FOGSI and as any other organizations, always we have a craving of the knowledge, and the knowledge spreads with the different things. We can have web meetings, we can have physical meetings, we can have seminars, webinars, and CMEs. So it's always good then when we talk in person to person, maybe in face to face. And I'm privileged today in front of Dr. Basir and Dr. Girija Wagh, who are much more senior in their own field and much more knowledgeable than what I am. And I'm having a privilege to share my some views about the drug of Ulipristal and Mifepristone. When we're talking about the fibroids, why one should be only talking about the medical management, and rightly said by Dr. Basir about the surgical management. So here we are talking about the fibroid as a whole, and when it should be undergoing the laparoscopy and when it should go for the medical line of a treatment. Because it's a disease of a reproductive age group as well as perimenopausal and menopausal age group, and everything has its own pros and cons. Because if you wish to go a surgery for the fibroids, there is a risk of anesthesia, there is a risk of post-operative complications, there is a risk for damaging the intrauterine lining, that is endometrium. And if the fertility preservation is considered, we definitely have different talks about it. So we will be talking about today what exactly the role of a Ulipristol and a Mifepristone in relation to the fibroids. One should be knowing about why at all we are talking like this and what is the prevalence of this. It is all of us knows from my friends, it is a smooth muscle tumor. It's frequently indicated for a hysterectomy. We know a certain part of India, though it is now a rare, but it is all of the uterus is going to get removed, and we have a beautiful slogan of a FOGSI, save the uterus. And that's why this is one of the important thing when you're talking about the fibroid management, and not the hysterectomy is the option only which is remain. Predominantly, the age group which is was positive in the prevalence of the fibroids is 40 to 59, that is 57%. And it is the same thing in India also. If you're talking about what is the prevalence, the approximately 15 to 20 million of the women suffer from this disease, and this is not something new. So fibroids is the most common tumors of the female genital tract. Most of it is a solid tumors. We know during the pregnancy there is a liquefaction or red degeneration. It may occur. It may have a predisposition factors that may lead to a pre-malignant state, and the malignancy is known. But most of them are the solid tumors, and then they are benign tumors. So when you are talking in general, it should be benign tumors. We know the different classifications. We come across with the ESG classification, FIGO classification, and hysteroscopic classification. As far as the myomectomy is considered, we know the Lasmer classification, where we see whether the one setting or the two setting myomectomy is helpful for the patient. All of us are knowing this FIGO classification by heart, and the postgraduates as well as the routine obstetrician and gynecologists, they know these are the types of the fibroids depending upon their component, intramural or maybe a submucous. It has to be removed, and it should not causing any effect. Why we should be talking about this fibroid positioning and their effect? But because most of them are asymptomatic. And when they causes the symptoms, what is the size of the fibroid? That is again the important thing. And what is the situation in which they causes the symptoms? If it is a submucous myoma and it causes a menorrhagia, the patient is symptomatic myoma. And these are the patient has to be going to have the addressing issues. If there is a 2 or 3 centimeter myoma, which has been documented by just ultrasonographic routine examination and she is asymptomatic, we need to take a little bit a step back, and we have to think whether that myoma is really a problem for her future things. Because a myoma, when you're talking about leiomyoma, it is having a slow progression and it is not going to get larger in a 1 or 2 days. So it has its own effects. The prevalence also, it is when you are talking about infertility specialist as well as the endoscopic surgeon, we are more worried when the patient comes to us for an infertility problem and she's having the fibroid. Then the $1 million question comes whether I should remove that fibroid, or whether I should remove, or whether I should leave, or whether I should go for medical line of treatment. So these are the population group wherein we have to think twice before we put the hysteroscope, or for that matter laparoscope. Even if you are doing something, mind well, what is the most important reason here is a myoendometrial junction. If the fibroid is away from the myoendometrial junctions, and if it is an intramural, we have ISHRE guidelines that these are the fibroids is not pertaining to the causative factors for infertility. So whenever you are doing the fibroids, the prevalence, we have to think about which population we are addressing to and what is the ranges. Again, the fibroids is depending upon their size, we need to have $1 million questions, the type and the common symptoms. Those are the fibroids which is in the smaller in size, and they are intramural usually they will not have a symptoms. But if there are submucous fibroids, or there may be a pedunculated fibroids, or there may be a symptoms, they may produce two types of the symptoms of a dysmenorrhea, menorrhagia, and menorrhagia could be which is a predisposing factor for anemia. And again, if the size of the fibroid is much more, we have a pressure symptoms. All of us knows from our postgraduate and undergraduate days, if the myoma is on anterior sides, it causes a pressure symptoms on the bladder, or maybe on the posterior side of the uterus, it causes the constipations. And even if it is a smaller size fibroid, sometimes if it is causing a neuromuscular junction problem, it causes a dyspareunia, and that is the one of the factors as far as the infertility is considered. The abnormal uterine bleeding, if you're talking about the patients coming down to us with the abnormal uterine bleeding, what is the main concern of the patient? Is the main concern is the quality of the life that is going to get hampered. If she is having a more menstrual bleeding during the menstruation, she is going for the chances of her absent from the work is much more. Chances of her going to the gynecological OPDs, are their visits are on a higher side. The worldwide prevalence is 3 to 30%, and in India, it is somewhere around 17.9%. Most of them has a quality of the impact on their quality of the life, productivity, and utilization of the health services. So if the patient is having just not a fibroid, the fibroid is the cause for her menorrhagia. That menorrhagia will cause into iron deficiency anemia, may cause her again the health problems, going to economical factors, and that is a huge burden on economical systems as far as the healthcare system is considered. The uterine fibroids, all of us know we have a good tool in our armamentarium, that is ultrasonography. Every gynecologist are using this tool, but mind well, my friends, when you have a good ultrasonographic machine, think of a 3D imaging, because gone are the days when we're talking about just the UHG. The UHG usually tell us it is a myoma, but if you are, it's not required a rocket science to delineate 3D. It just there is a software in ultrasonographic machines. You have to have your training done in that particular fashion, and then definitely why it is important, because it will tell you the exact site, and the decision on that particular things will be deciding on the factors. If it is a multiple myoma, whether it is a corneal myoma, whether it is a cervical myoma, your thinking process will be different. You will be having much more clarity when you are talking to the patient in OPD. MRI is better than the CT imaging. We will not usually for that myoma, we are all of us not going for this particular investment of the investigations, because they are costlier. If you have a small myomas which can be diagnosed by 3D ultrasonography, it is much more convenient for you to understand and you to deliver what is kind of a treatment she is required. Saline hysteroscopy, definitely if there is a small myoma or there is a submucous myoma. Why it is important? Because if you are doing a saline hysterography or maybe a saline sonography, you can come to know what is the stock of the myoma, whether it is a vascular, then your operative procedures will be easier. If it is a vascular pedunculated fibroid, I will be using a bipolar resectoscope. If it is just a smaller bleeding, I will not use any energy source. So that a mindset, you can go into the OT and you can finish your job. Definitely laparoscopy and hysteroscopy is not for the diagnosis. It is a therapeutic option also. There is nothing called as a diagnosis nowadays. Your diagnosis should be prior when you are going to the OT. You should be very thoroughly and mentally prepared what you are going to do when you enter the OT. So the laparoscopy and for hysteroscopy, I think it is a much more not for a diagnostic. It has a modality of the treatment option. I told you about the classification are n number of classification. Even if you're just thinking of a myoma, of a submucous myoma, we have two classifications. So what this classification in general tell us? This will tell us that these are the myomas. If it is going for the operative procedure like a hysteroscopic operative procedures, whether you can with your own efficacy can go for single step procedure, or maybe you can complete it, or you require a laparohysteroscopic approach, or you can done it only with the hysteroscopic approach. Because when we are talking about the minimal invasive surgeries, it should be always a minimum. If you are very much 110% sure about the hysteroscopic myomectomy, there is no need to put the laparoscope in order to see what you are doing. No, it is gone are the days where there is a laparoscopic guidance myomectomy has been done. If you are very much thorough in your mapping of the myofibroids, definitely you will come to know what approach you are going to go with. Pathology, now we are not discussed much more, that is, it is estrogen dependent. That's gone. That etiology is a past decade now. What we are talking about, the estrogen receptors and progesterone receptors. It is a progesterone which is now coming up in a very big way, that plays a role in a formation of the fibroids and the growth of the fibroids. Again, these are, when you are talking about the genetics, the genetic plays a role. There is a different theories wherein there is a history of a gene which is responsible for the fibroid pathology and the recurrence also. So if she is having the familial history of the myoma, you should be dealing with the patients, that you should ask and you should correlate with your findings. Role of progesterone. Now, previously we thought about it's a estrogen dependent condition. So that's why I told you this is the gone of the days. We not never now thinking of it as a estrogen dependent, because if we thought of the girl is more feminine, she will have a endometriosis or she will may have a fibroids. Gone are the days. Now we talk about the receptor levels. We talk about the molecular levels and what it happens, that it has the progesterone receptors, and which will cause the growth of upregulating epidermal growth factors, as well as it inhibits the growth by downregulating insulin-like growth factors. Just to think that there is a, in a body, when you're talking about any pathology, there is a downregulation and then there is upregulation. Certain things are going to get upregulated, and that's why this particular disease is going to have an upper hand. When you're talking about some of the genes or some of the factors is downregulated, you have a shrinkage of the disease or you have a regression of the disease. Similarly, what are the management options we have? We have definitely a surgical, medical, and non-surgical alternatives. When it is depending upon which modality suits the patient, you cannot just enforce that I'm a good laparoscopic surgeon, I will make a Guinness World record that removing minute 1 millimeter myomas, 30 myomas. Gone are the days. The people in the world will laugh at you. It's depend upon what is required for that patient. If you are doing a 31 myomas and none of the myometrium is left behind, she is not going to go for the fertility. So think in the ratio which option is required for that particular patient. Like uterine artery embolization, there is a good thing as well as there is a bad thing about it. Similarly, GnRH analog and the newer drugs, we definitely know there are the bad effects, there are the side effects, and there are the good things about this particular therapy. So if the patient is coming down to me, think the patient as whole. You shouldn't be thinking about her age, about her reproductive career, what is the recurrence, what are the side effects, what are the complications which is going to take place with this particular modality of treatment. So what are the uterine fibroids? The current opinions are, if she is having the expectant management, in whom you can give expectant management, she has a immediate menorrhagia and you don't have any other treatment, you can just give a expectant management because she is not ready to take any other opinion from you. She has come down to your OPD and you are just giving her, these are the options which is available, but immediately you can give some hematinics, maybe NSAIDs and fibrinolytic agents, which will antifibrinolytic agents, which will stop or which will decrease the blood flow. Medical line of treatment, definitely we have GnRH analog, we have SPRMs, we have a progesterone releasing intrauterine system, that is a Mirena or LNG IUCDs. We have oral contraceptive pills, but that will depend upon what is the urgency, what is the cause, and what is the how much is the time that is required for that particular action of the drug to be taken place. Surgical management, definitely a myomectomy and the hysteroscopic myomectomy, if it is a submucous, depending upon the whether it is a intramural, whether it is a submucous, or whether it is a subserous myomas causing any of the symptoms, then and then only these are the surgical opinions should be one of the choice. Limitations of current pharmacological treatments one should be knowing about, because if you are prescribing some drugs, the some drugs are going to have a disadvantages and some drugs will have advantages for using it. Oral contraceptive may increase the size of the fibroid, and you know, if you are giving a not a cyclical or continuous, even if there is a chance of breakthrough bleeding, even if there is a estrogen. Now I know I'm elected as a family welfare committee chairperson of the FOGSI. These are the good drugs, or maybe a good OC pills are coming up, but definitely there is estrogen. If you are giving high dose of estrogen in order to stop the bleeding, see, for a stoppage of the bleeding, you require higher estrogen content OC pills. So it is when you are giving that estrogen on the higher side, there is always a risk of venous thromboembolism. and you must be thinking in that particular way of line. Progesterone, definitely there is interconsistent bleeding pattern, hypoestrogenic side effects, all of us knows, follicular cyst. This is the better being seen by none other than IVF specialist. If you're giving a progesterone withdrawal bleed at the day 2, if you do the scan, you will find out there is a residual follicular cyst. This is a common finding. LNG IUCDs, you have to think about what is the expulsion rate, whether the uterine cavity is regular or not. If it is not been that, then there is no point in just putting the intrauterine cavity like LNG IUCDs inside, and she will in next period it will expel out. So you need to think, and that's why my beginning of my talk, I told you to do a 3D ultrasonography by yourself. If uterine cavity is good, you have a regular cavity, it is better that you should have this option with you. Then what comes next is GnRH agonist. Huge fan followers and huge market, and there is a huge cry for a GnRH analog. Whenever we are talking about IVF patients also, we give a down regulation with the GnRH analog, we give a endometriosis GnRH analog, we give fibroid GnRH analog. So what is the things that one should be knowing this GnRH analog? If she is an adolescent girl with the, unfortunately with the myoma, one should be saying no to this drug. Danazol out of question. So this is one should be very thinkable. When you are giving GnRH analog, this bone mineral density is going to go down. You have to give add-back therapy. So that is the one thing one should be when you are prescribing the drug, when you are giving the depot, because one shot has been given, you are calling her after 3 months. So think in that line, and which age group you are addressing. Secondly, if she wants to have just to temporary management with GnRH analog, you are giving it. There is a those who are doing a laparoscopy, they must agree with me. If you give a GnRH analog and you post the patient for laparoscopy, it becomes the myoma will come in piece and bites. So it's a difficult myomectomy you will encounter. So whenever you are very clear which method you are going to do, then choose accordingly. Symptomatic treatment, it is better to give a hematinics first, because no effect, it is better to increase the hemoglobin level. But what is the loss if it is like a tank? If you are giving a hematinics and she's menstruating heavily, it will not increase the optimization of the hemoglobin level. So in that particularly symptomatic treatment for expectant, it is a good drug to be used. Secondly, newer options available. Then every armamentarium you have something new come up. Pardon me for saying like that. The pharmaceutical industries come with something new, then it goes down, again it comes back. There are certain things which is being motivated, but one thing one should be taken into account, what is the best for the patient. Similarly, when I said no to the danazol, maybe there is a market a few years back. We don't use it now because of the side effects. GnRH analog, I will be saying it's for the temporary things where a surgery is not been option. Similarly, SPRM is a selective selective progesterone receptor modulators. What it causes, it has a different actions. It has a molecular actions. It has on a fibroids, it causes apoptosis of the cells. It causes decrease in the volume of the fibroids, and it definitely have a certain effects. Then all of you will vote for me and will start writing on the comments that this is a ban and all that things. I will come back on this particular points in a while. So we do have certain things in our way. What is that? Is a Ulipristal acetate. In 2011, this or prior to that also, the Ulipristal acetate was in the market. It was being used, and certain things happen, and it causes a little bit backstage. Again, it is coming with because we require evidence in the science. Without evidence, we cannot just say this is a good or this is bad. So if you collect the good evidence, if you have a randomized control trials, if you have a safety profiles, then you have the gold in your hand, which is been brighter than anything else. So what is it? So we have definitely Ulipristal acetate comes in a 5 milligram and 10 milligram. They have again the Pearl 1, Pearl 2, Pearl 3, Pearl 4 randomized control trials. They see what is the efficacy of drug. See letrozole, why the similar way, letrozole why 2.5, why not 5 we give? Similarly, why Ulipristal 5 should be given, why not 10? So they have a comparison. That is the efficacy of the both the strain is the same in order to achieve the stoppage of bleeding, maybe in a 5 to 7 days. And if you are giving a 10 milligram of Ulipristal, the size in reduction and maybe a prolongation of the amenorrhea in number of population they have observed is not statistically significant. What is the statistical significance? your statistical significance is p-value is should be more than 0.001 at least. So in that regard, if your higher dose is not going to have a suffice the same thing which can be achieved at the 5 milligram, why to increase the dose of this? So Ulipristol may be effective in a 5 milligram. I'll come down that particular things. What is the mechanism of action? You must understand every drug in a particular way. It has a mechanism of action. It has a T half of a drug, elimination of the drug, and what is the residual of the effect of the drug for a longer time. So what is the mechanism of action? It causes a suppression of a neovascularization and cell proliferation. It causes down regulation of angiogenetic factors, inhibition of ovulation. That is mandatory. You must remember, if you started Ulipristol, she has been be away from fertility for that particular reason. Reduced in collagen deposition. Why that is important, collagen? Because if you remember the fibroid has a capsule and the capsule has a collagen. So if you have reduction in the collagen fibers, it is always better that the size of the fibroid will shrink down. Induction of the cell apoptosis. One must be here giving the importance that there are the drugs which will cause the reduction in a myoma and it will again regrowth of the myoma. If you have a cell apoptosis, the cell cycle is going to get death, and the death will not cause regrowth of that particular regeneration of that cell. So that is the one of the effect of the drug. So coming down to the mode of actions, the Ulipristol has a hypothalamus pituitary. All of us are knowing this particular HPO axis. But mind well, when you're giving the drug, I said no from the fertility as far as the ovulation is concerned. Then you will ask me what is the effect of the endometrium, because it is a progesterone. Any effect, because if it releases selective progesterone receptor modulators. So there are the receptors on the endometrium. The endometrium has the estrogen receptors as a progesterone receptor. So that particular receptors is going to get agonist or antagonist effect. What it will first it will cause is it will cause a hyperplasia, and then it causes atrophy. So that is the one of the thing is the first it causes a progesterogenic action, and then it is called as antagonist effect of the progesterone. And that is the one of the thing one should be taken into account when you are giving a Ulipristol. The Ulipristol per se causes endometrial hyperplasia, but mind well, they had taken the endometrial biopsies in a multicentric study and they not find out any of the malignancy or precancerous changes which has happened into the endometrium. So that is already been ruled out. Then coming on to perimenopausal, if she is atropic, then what will happen? Whether that is atropic endometritis and all that thing will come into your mind. I know that because it has anti-progesterogenic action. But that action will be for that duration only. Once the drug is being stopped, you have again re-ovulation is going to occur, because we had our own series. I'll put my slide there. I'll tell you, this is my original paper when we done it 2017. So authentically, I can tell you the comparison between the two drugs. We have a data of our patients and everything. So we'll come down to that later. So that will gives you a pharmacokinetics. So you will ask me, if 5 milligram is the dose, how prolonged I can give, or what is the time schedule I can give. See, it can be given within a first 1 or 2 days of the cycles. When you start it, you have to give the Ulipristol, and Ulipristol at least should be given for 3 months. You cannot just say giving a 1 month and then going for a fibroid mapping again and then saying the fibroid volume is not decreased. It is not. Every drug has its particular action. So you have to wait for that particular period of time. So again, your controversies come, then why it has been stopped and why it is again been reintroduced and why I'm talking about it. So why it is? Because it causes some side effects. First is a majority of them has found out there is a headache and nausea. If you compare all the studies of Ulipristol, you will find it out. Majority of the drug effect is a headache and nausea. After that, there is a liver dysfunctions in whom where they found out there is an underlying pathology of the liver dysfunction. So it is always a mandatory when you are talking of some drug, take a thorough history. Take a history of the patient, whether she has any hepatic problem in the past, or whether she has undergone some medications for the liver disorders. So if you have that history, definitely you are going to do the liver function test. Even if she is not having that particular history, it is mandatory that because a DGC has given this particular order, and it is always better to be in a system rather than out of the system. It is better to do the LFTs and found out for your safety that she is not having any underlying liver disease, and then you can start it and you can give it for 3 months. And before, once you started it, what they are recommended, you have to do it every 2 weekly for first month, and then you can do it after the 3 months. And how many cycles you can give? There is a called as cycle duration. If you wish to give a Ulipristol can be given for 3 months. Then you have to wait for the menses to come again for the next menses. So out of the things is 1.5 months will go. That once the menses will come, maybe 10-15 days the menstruation start, and the next menstruation start after 1 month. So we already have that backlog of the drug which is gone and out of the system, and then you can start the recycle, and the recycle is of again for 3 months. So how many cycles you can give? You can give 4 cycles maximum, that what has been done and what has been quoted in the studies. Then they find out what is the comparison as old brand of a Ulipristol. I already covered this. How many and which are the fibroids? These are the candidates which in whom you can use the Ulipristol. And what is unfit for the surgeries? There are certain indications. There are the certain indications. Is first, if she has a menorrhagia, she is symptomatic fibroids. In order to, you are taking a time to build up your hemoglobin levels of the patient. That is the first indication. Secondly, she is not immediately having unwilling for undergoing the surgery, or surgery is contraindicated for the patients in perimenopausal age group. And prolonged treatment is required. A postmenopausal symptoms are more frequent with the Ulipristal acetate than UPA, because Ulipristal acetate, all of us know, give a hypoestrogenic conditions, and that usually are worrisome to the patient, which will not occur with the Ulipristal acetate. So contraindications, I already mentioned that if she is having a liver diseases, maybe a genital bleeding with of unknown etiology, uterine, cervical, ovarian, breast cancer, or maybe the history in the family. UP is not intended to use in a postmenopausal woman. So please be very choosy in selection of the drug, because if you started the drug and if something happens, you are at fault, because the drug is not at fault. You need to understand in which patients you are going to start this drug. Secondly, when you are talking about Pearl studies, which I was mentioned prior, Pearl 1, Pearl 2, Pearl 3, and Pearl 4, what they compare is a first is the dose, 5 milligram versus 10 milligram. Pearl 2, which compares a GNRH analog with the drug, and Pearl 4 with the longer duration. And the latest, like a Pearl 4, evaluate the administration of the 2 courses of 3 months of 5 milligram and 10 milligram. So the drug and our medicine is always I start my lecture paying tribute to the knowledge, because I firmly believe if the knowledge, you have the knowledge, you can sit anywhere in the world respect your knowledge, no matter how junior or how senior you are. Similarly, how it evolved with your patient's references, your clinical practice. There are the side effects, there are the so your meta-analysis, your retrospective studies will tell you which are the best one. So when you are talking about the statistical and characteristics, I told you why these are been studied. The Pearl conclusion that the bleeding is controlled in 91% at 13 weeks. So majority of the bleeding will stop in first 5 to 6 days, but of some of them are excluded. They will take a longer time, but amenorrhea occurs within 6 days in 73%. The volume reduction of the fibroid is 21% and 54% at the course of the 2. I will go to the different slide here, because I wish to show you how much is the decrease in the volume once the course has been started. So it from the 1439, it will have the highest efficacy of 67. That is the 4 courses. After that, we need to talk about the follow-up and the recurrence. I will be coming down to that in a little while. So if you give for 3 months, you will thinking that, please mind well, my friends, you have to start the drug. Then after 3 months, do the scan. It should not be the intermittent scan to see whether the fibroid is shrink or not shrink. It has no meaning. So when you're doing after 3 months, you'll come to know what is the shrinkage and what is the percentage. And then you can compare. And if you have a good sonologist, like in city of Pune, we have a different sonologist who map the fibroids also. So give it to them. You have your own studies to publish. That is one of the way forward of any of the drug for that matter. So the DGCI come with the approval letter on 13th of December 2021. Mind well, on the right side of the screen, if you see, the drug can be used to treat the uterine fibroids in premenopausal women. whom surgical procedures are not appropriate or have not worked. So that is the first thing. Secondly, drug must be used to control the system of uterine fibroids while waiting for the surgical treatment. That is the second one. They're not included reproductive age group. They're not included postmenopausal because that is a contraindicated in a postmenopausal. In a reproductive age group, it has not been mentioned, but all of us are using it. But then warning should be included in the educational materials from the doctors to the patient that these are the drugs which may cause liver function disorders, and what are the indications to stop down the drug, or in which indications you will say I will not use the drug. If you do the LFTs on prior to a starting of the drug, and if you do the LFT again and you find out there is an increase in a trend or maybe 2 times increase in LFT, it is a warning thing for you. If it is 3 times increase, you have to stop. You should not use this particular drug in lifelong. So this is very clear cut. All of the message should go. So it is not the per se the drug is dangerous. No, if the patient is having all LFTs normal, if she is into the fibroid and she doesn't wanted to have the operatives done, or maybe there is a hemoglobin which is low, we wanted to have some time to build up the hemoglobin, this is the drug in the market or in the world to be used for. Then coming down to the DGCI approval, I already talked why it has been backlog for 2020, and you see if you go into the review literature of this Ulipristol and when it is going is banned and why it is banned, you can come to know. I will not going to mention this on this platform because once there was a ban on this drug, another drug came into the market. So if you compare the 1 month span, you will come to know what is happening that time. And if you are comparing the number of patients and what is the liver transplant cases and all that thing, because they had a previous history of liver dysfunctions, and that is not been looked into much more in details. And that's why a DGCI comes with the appropriate guidelines for all of us to use this particular drug. This what I already talked about. This is a monitoring chart when you are going to do the liver function test, monthly liver function test, and maybe how you can give 3 cycles, maybe 4 cycles they are tried up. And what they are given, these are the guidelines. See, always you follow the guidelines. Guidelines are not the rules, but it is a moral responsibility of the treating physician. So it is always better. These are the indications I will follow. These are the things I will do. I will do again the LFTs and again confirm whether the LFTs are normal or in, because if they are saying it to be used in a pre-menopausal woman, all of us in Indian standard must look at our mothers who are in that age group having a lipid profile or maybe underlying diabetes or maybe hypertension. You must think in that line when you are starting this particular drug. Coming down to the restricted use that already been, I was talking about my own research paper which was published in 2017, and this has been cited by many people across. And what we found out that time is we had given the Ulipristol for the fibroids because there are tiny fibroids and which are near to the myoendometrial junction. So we had given the Ulipristol for 3 months, wherein the fibroids, some of the fibroids vanished, some of the fibroids gone away from the myoendometrial junction, and we had done a embryo transfer later on. That is always a FET after the spontaneous menstruation has been occurred, and we found out these are the case reports from our country of India. Again, we have something in our armamentarium we should be talking about. That is, I will be taking 2 more minutes to talk about it, is a mifepristone. But in order to summarize this drug is a beautiful when there is a patient of a heavy menstruation comes to you with the known etiology of the fibroid. It is better for the correction of anemia, and because it's acting faster, it causes amenorrhea in a 5 to 6 days, and the tolerability of profile is much more higher as compared to the Lupride, because there is injection pain, side abscess, all of these are can be ruled out. The results of the significant reduction of the fibroid, if you compare the fibroid reduction size in a Lupride as well as the Ulipristol after the 3 months, because see, why 3 months? Where is this 3 months comes? I can tell you another good story about it, because Ulipristol is given for 3 months. You need to compare with the Lupride acetate, and the Lupride acetate you give every 3 months. So when you have ball to ball or maybe a apple to apple comparison. It should be that comparison. And that's why 3 months, when you're thinking of reduction in the size, the reduction of the size in a lupride group is 51%, and that to be UPA is on a higher side. Keeps estradiol levels, because why it doesn't cause hypoestrogenic side effects, because it will not causes hypoestrogenemia. It keeps the estradiol levels to the mid follicular range. It reduces the incidence of the hot flushes and also on the bone and bone mineral density. So coming down to the another summary of it, whom to give, I already mentioned it quite a lot of time, so I will not waste time on that. I will switch over the another drug which is there, not been marketed for, approved for that matter, by any of the appropriate authority, because it's an off-label indication. All of us know Mifepristone, again it is a SPRM, so it has the same effect. But when you are comparison with the something, so they compare with the drug. First they compare with the 25 milligram with the 50 milligram, then they compare 50 milligram once a week, then they compare Mifepristone daily 25 milligram and 50 milligram. So what they find out, that 25 milligram, if you're given it daily for 6 months, 47% decrease in leiomyoma size and 53% in the uterine volume size. But mind well, when we are talking about the price and all that things, so that's why these papers comes in, because Ulipristol is much more on a higher cost as compared to the Mifepristone. But if you're comparing the results, we had done our own study, I can tell you, and I can go to our own experience, wherein we compare the head-to-head comparison between the Mifepristone and the Ulipristol. What we found out that whenever the uterine size is smaller, the Mifepristone and Ulipristol is affecting the best way. But if the size of the myoma is more than 5 centimeters, or maybe because indication of Ulipristol is a 5 to 8 centimeter myoma, you can take care by giving a Ulipristol. And in those patients, what we found out in our published study, that it is a beneficial in a larger myomas. But if it is come down to the minute myomas or a minor, both of the drugs has its own role. So in order to conclude my talk for that matter, last slide, it's a first, when you're giving any kind of a treatment for that matter, it is the first is a profile of the patient, that is much more important. What patient needs, that is another important thing. What you need is not the important thing. That I am a good laparoscopic surgeon, I will do only laparoscopic myomectomy is not the answer. What is her age, that is another important thing. What is the number of myomas, what is the site of the myomas, and what is the previous history or previous profile of the patient, because certain drugs has certain effects as well as side effects. So all of us can have a different roads, we have a different beautiful sceneries amongst us. At the end, we should reach to our destination, but we should enjoy the journey to the right path. So thank you very much for your patience hearing. I'm available for any questions for that matter.
Thank you very much, Dr. Ashish. Now we have the expert commentator with us, Dr. Girija Wagh ma'am. She's a professor and a senior consultant at Cloud9 and Apollo Hospitals. And she's the elected VP FOGSI West Zone for 2024. So I'll request Dr. Girija Wagh ma'am to please share her expert comments.
And my teacher too.
That's so nice of you to continue to call me your teacher, Ashish, because now you've become a colleague and I'm very proud of you and your presentation, your publications, your experience, and the amount of good work that you are doing in the field of OBGYN. And that also makes me feel that we are getting older and older, but we know that the future lands in the hands of people like you who would take rational decisions. And you really got into a lot of insights, not only about information and experience and the various licensing that is available with the drug, and basically bringing up a promise of not only going by, just by looking at a sonography of your diagnosis, but going into the details of mapping. And that's very important, because if you are not ready with what you are doing, and then if you're going to land up in surprises in your operation theater, that means you have not planned your surgery well, and you may cause more harm to the patient than good. One of the important aspects which I want to bring to the notice of everybody is Unfortunately, women are made to undergo hysterectomies just for an innocuous benign fibroid, which actually would just shine maybe during her perimenopausal transition for a little while, compounded by her anovulatory bleeding. And that is a time wherein these medicines will help her to ensure that she doesn't bleed unnecessarily and is warded off that particular journey and can sail through. Especially women who are obese, women who have hypertension, women who have diabetes. All these women are the right candidates for this kind of a treatment, which will help them to not only save their uterus, because whatever comes, hysterectomy is not associated with any kind of a safety. It is an interventional approach, and it definitely causes more harm than good. And there are a lot of stories that women have to tell post-hysterectomy, and that can really, really disturb their quality of life. Coming to the infertility aspect that you brought about very importantly is, sometimes I'm really surprised that unnecessarily people would go into the recourse of doing a surgery just because it is doable, or just because you have the technique, or just because you have great imaging. But as Ashish rightly brought about, it is not the right approach always. You have to be very rational, you have to be very choosy, and you have to be absolutely careful. Are you taking the right decisions? Because once an intervention, always an intervention. This woman is going to have challenges. And these medicines have gone through rigors of many studies over a period of time, and they have proved beyond doubt that they are effective. Not only are they effective, they are actually, if we look at the study of the drug, I'm sorry, I'm not getting the name. Ashish, if you could help me.
Yeah.
The Ulipristal Acetate. It has gone through trials. It has gone through various trials which have been in context of infertility. Now, what is important about these trials is they went and studied, and they went through 4 trials, and all of them proved that they can bring about a real remarkable shrinkage. And one of the contraindications for sometimes an unsuccessful embryo transfer could be an intramural fibroid. And these studies have shown, we can't forget them. And if now we have been proposed to look at them with an open mind, with a relicensing, I think we have to take it up and look at it a little positively, because finally a surgeon or a physician or a clinician is the one who is always able to take the balanced decision and deliver the results that are necessary for the patient. And if you are not able to deliver those, then that's not right. Now, for example, I would like to mention what you said was about the fibroid and pregnancy issue especially. I have had not 1, but 2 or 3 patients visiting me recently in the past about 2 to 3 years who became pregnant with a fibroid. And they were made, they were suggested in the first trimester itself to go in for a medical termination, take a myomectomy, and then plan their pregnancy. I think this is very irrational way of approaching, because fibroids in pregnancy, if the woman has become pregnant with a fibroid, that means that uterus is functional in all its ways. The uterus is meant to get pregnant. And if it has become pregnant, that means now it is your responsibility to carry it forwards. So we have to be very balanced when we guide our patients. We should not scare them. However, one of the most important things which we have to always remember is one thing which he mentioned was some of the fibroids would have different kind of receptors. So you will have to be looking at them when you give medicines. You will not just write the medicines and go off. You'll follow a standard protocol, see whether the patient is responding to that medicine, because it's possible, because it's not always practical to do the receptor studies. Maybe 10 years down the line, people will do gene typing and receptor studies, and things would be easy. But right now, at this point in time, since it's not accessible, always keep your patients under follow-up when you're using these medications. That is point number 1. And secondly, please do the imaging correctly. If you are not doing it, ensure that the imaging has been done properly. It's not like do a sonography, then do an MRI and do a CT scan. No, you have to be able to correlate everything clinically. And especially if there is a fibroid which is undergoing a degeneration, maybe, and most likely it is not going to respond to these medical lines of treatment. This understanding is very important. So while we are writing this medicine, they are not essentially a panacea, but they have a very, very important role to play. And we have to have an open mind, because, we as Indians are very, very popular abroad, across the world, to deal with fibroids. And nobody can take away that expertise from us. We already on this forum have a Guinness Book, a record maker who's taken a big mass off. And we also have Ashish, who has no less fame across the country. And I must also share an example with you. Just before COVID, I had a woman coming down from US. She was unmarried, and she suddenly got diagnosed with a massive mass. And then she came and she said, doctor, I visited everywhere in US, but I have only 15 days window. And I went everywhere. They told me so many options, but finally one of the Indian doctors there said, go to India, because India has the best doctors to deal with fibroids. So she came down to Pune. We did her imaging. It was a massive fibroid equivalent to a 38-week size pregnancy. You can imagine what a big fibroid she had. And we did a laparotomy. We removed the fibroid, did a wonderful myomectomy for her. It was absolutely an umpteen task to deliver that fibroid outside her body. And then we gave her a wonderful, seal on her abdominal wound, incision. After 2 years, she came down because she lost her father in COVID, and she showed me her wound. There was no scar seen on her tummy. So therefore, we have to understand how to use our, we have a lot of arms in our hands to deal with problems like fibroids. It's very important that we remember them. And the last point that I would like to make is, friends, do not forget that fibroids which occur after the 5th decade of life, and especially if they are de novo fibroids, they can be cancer. They can be a leiomyosarcoma. And therefore, your imaging, your understanding, maybe an additional imaging would help you to make a decision, because there have been tragedies across the world where myomectomy was undertaken laparoscopically. And then, morcellation was done, and there was upstaging of this cancer, killing those women just in a period of 2 to 3 years. So therefore, we have to be very careful when we make our decision, take care of everything that is there in your batteries. I always remember Professor M.B. Agarwal saying that the investigation, test, imaging equipments have been created for the safety of the human beings. So don't get wary. Sometimes patients say, "Bahut mehenga hai, madam, I don't want to do it." You have to encourage them. You have to tell them that these tests are going to help us to make the right decision for you. I hope I have been able to summarize effectively. Thank you so much for giving me this opportunity to share my viewpoints. And thank you, Ashish, for giving us that wonderful talk.
Sir, there are a few questions in the Q&A box. There is a request for repetition of the regime and contradictions.
You want me to say, you had to remember 3 months, give for 3 months, wait for the spontaneous menstruation to come. Next menstruation, again, you have to wait. After the next menstruation, you start for the 3 months. So what they have done in a longer study, they given for 4 cycles. So that is the regime. So it will depend upon what is the size of the myoma and how long you can able to give. And again, the follow-up, like DGCI given every 15 days to do a LFTs for first month, and then after every month.
So Dr. Namita Grover, she also asks whether ultrasound abdomen has shown grade 2 fatty liver. So do we start?
See, that is the factor I told you in a perimenopausal age group. All of us, when you see our mothers, definitely there is going to have some damages or maybe a hypertension, diabetes, fatty liver. So it is better to evaluate the patient per se, not for all. If I talk like you do a sonography abdominal pelvis for every patient, it is not right. It is better to do evaluation of the patient, and if she is having a fatty liver, it is better to do LFTs.
There's a hand raised by Sheikh Malika. So Dr. Malika, if you would like to speak up.
Yes, ma'am. Thank you, ma'am, for giving me the permission. So good evening, sir. Recently, a lady has come up. She is 30-year-old with secondary infertility, and there were 2 fibroids. One is 4.5 centimeters in the fundus, one is 5 centimeters in the anterior wall of the uterus. Both are intramural, and she is anxious to conceive also. So the best treatment option would be a myomectomy, or and she is not willing for the surgery immediately. So in the meanwhile, can we keep Ulipristal followed by myomectomy, or better to go directly for myomectomy?
Yeah, that's the take-home message I can say. If you wish to do a certain treatment, you follow the. You cannot give a half-heartedly. I give a Ulipristal also, then laparoscopy also, then again I will give a Ulipristal. No, If you are thinking with the mind and with your vision that if you go for a laparoscopic myomectomy, it's better to finish it off. But if you are giving a Ulipristol, it will shrink the size, and that to be, if I am not mistaken, if you are given for hysteroscopic myomectomy, Lupride, which has been studied, it reduces the size, and so it will decrease your operative time for a Lupride acetate. For Ulipristol acetate, I have not come across any difficulties in lap myomectomies after UPA has been given. So I think Girija madam will tell more about it, because I have not come across any of the literature finding it difficult while doing a laparoscopic myomectomy.
There is
So
no
there will
difficulty.
not.
There is no difficulty as was experienced with the GnRH analogs which were given as preceding medicines. So you can consider giving, but I would still vouch for giving Ulipristal acetate, as is said by the Pearl 3-4 trials, that it will shrink, and then that would be our window of opportunity to plan a pregnancy without she going into a scarred uterus or anything. But depends on what is her ovarian reserve, depends on her age, depends on her other fertility factors also. Because it's not always the fibroid which is responsible for her delay in conception.
And secondly, there are the two myomas, one on the fundus and again another in the anterior navel. If you're giving any incision whatsoever, you're going to have a weakening of the myometrium. So think in that line also.
Yes, sir. So there is no harm in trying the Ulipristal for the respective 3 months or 6 months.
Yeah.
Yes, along with so many other things, lifestyle change, so many, everything you start, women do conceive, you just have to spend a little time with them. I'm saying something contradictory to what Ashish would say. Ashish is a very, very popular IVF specialist in our city. But I am also a very popular gynecologist to avoid IVFs.
Thank you, ma'am. Thank you, sir.
Thank you.
There's a question by Dr. Meenakshi Taneja. Recommended dose of Mifepristone, please.
25 milligram daily. I have been using it. There are the studies of 50 milligram once a week, but I have not used it. 25 milligram I had used it and found out very effective when the myoma is less than 5 centimeters. Equally with the Ulipristol, but not more than that. We in our studies we don't find it more effective than the Ulipristol. If it is a multiple myomas more than 5 centimeters or equal to 5 centimeters, Ulipristol acts better.
Okay, what is the treatment in postmenopausal women unfit for surgery? This is Aprajita Nandra.
Postmenopausal, because see, it is now contradictory, contraindication for DGCI. Postmenopausal, you lady with the myoma, you should not be, because there is a high incidence. What madam was saying, if there is in that age group, if you are finding out the myoma, chances of cancer is much more higher. So that's why Ulipristol is contraindicated. So in those patients, you need to have a good imaging done. What is actually the things are? We need to have a surrogate markers of the myoma or leiomyosarcoma. So if you are thoroughly evaluated, then you are taken a call whether to go for surgical or just to wait and watch or expect and manage.
Can I also add a few things to this? Because if it's a woman who is bleeding, always do her endometrial sampling. Do the red flagging for CA endometrium, because that is coming up earlier in the age groups in the current scenario with PCOD, obesity, and hypothyroidism. And then if everything else is fine, you can actually sometimes consider giving them other sperms like SPRMs or SERMs like ornaloxifin, or maybe even a simple thing like progesterone, DEMPA, that would help them. Or simply giving, if she's postmenopausal, established menopause, then you may consider giving her a GnRH agonist shot. Just give one luprilide, and that takes care of most of their problems. But then these all have to be balanced properly in a clinical context. But these are the options available.
There's a question by an anonymous attendee. Can we use Ulipristal if there are intramural fibroids in a patient of infertility?
Yes, that is what it is for.
Yeah.
You can't use it in a submucous fibroid, though. Please remember, submucous fibroid, it may not respond to. However, few studies have shown it will. So you have to take a call, because submucous fibroids will definitely act as an interference to a pregnancy implantation.
There are a couple of thank yous.
Having said that, Ashish, I must say, I'm sorry to interrupt you, Deepika, that I recently had a submucous myoma patient conceiving. In the first time when she lost her first baby that was having a problem, so we decided to terminate that baby. I could feel at the time of DNA a large submucous fibroid inside. And then I said, let's wait on you for a while. Anyways, you had conceived last time. So we'll just wait on you. We'll control your hypertension. And then she simply came pregnant after 1.5 years or so. And that time that submucous fibroid was nowhere to be seen. At the time of Caesar, we saw one small little pea there. So, they also behave differently. So you have to just be on guard and continuously surveillance and making switches in what is going to be best for your patients.
True, madam. Because what I feel, no, that small pea like a fibroid, if it is there, and if it is a submucous, eventually, if you like you taught me, the myoma, submucous myoma, pedunculated starts from the growth, and then it eventually goes from the cervix. So if it is a smaller myoma, may sometimes not a actually causative factor for the infertility.
Absolutely.
So this is the last question by Dr. Chetna Ramani. This is 48 years, 2 large fibroids, 6.5 and 5 centimeter, menorrhagia. Can we wait for menopause or treat surgically? FSH is normal at this point.
Give Ulipristal now. And let her get menopause happily.
It's better, no? Give the Ulipristol and then it will shrink, and then she's already into that age group. So what our old school thought is like when she entered into a menopause, fibroid shrinkage. So wait and watch. At least give some trial rather than the myomectomy and hysterectomy is not indicated.
I have several patients who we have deferred my hysterectomy in this age group.
True.
There's no need because that uterus, poor thing, is acting as a support to your nerves, which supply the bladder, the rectum, and it makes women feel nice to have uterus inside them. So why remove it? Ugitsats.
So couple of thank yous are there in the Q&A box. One is Dr. Emily from DRC. Thank you, Dr. Ashish. And another is Dr. Sunil Shaw. A great presentation. So this is a good opportunity right now for all the attendees to interact with the faculty. If anybody wants to speak up, please raise your hand. Otherwise, we will be closing the webinar soon now. Yeah, there is Dr. Upma Jaiswal. Please speak up. Unmute yourself, Dr. Upma.
Yes, ma'am. I would just like to ask if we are waiting for embryo transfer of a patient, like we have made the embryo, and then fibroid is encountered, like we know it beforehand also. So can we get Yulipristol and decrease the size, and then again, then do embryo transplant after 3 months or after 6 months when the fibroid shrinks? Is it possible?
Yeah, that was my study in 2017. Same thing what we had done, madam. That time we had given this Uterine and there was a multiple myomas. So it is difficult to do the laparoscopy or maybe a myomectomy because the chances of harm to the uterus is much more. So we had given the Uterine for 3 months, wait for the fibroids to shrink away, or if there is a myoma which is causing the distortion of a myoendometrial junction, better to wait and then do a FED.
But sir, with embryo transplant, we have to give estrogen support and other things. Will it not again cause
no, that's
like
the reason. If you can go to the of a Ulipristol never cause hypoestrogenemia. The mid follicular level of the estrogen is maintained. So once she has the bleeding, spontaneous menstruation, you require the same AFT protocol as that of the AFT protocol of the normal patient.
okay.
Not required a higher dose of estrogen.
Okay, thank you, sir.
Thank you, ma'am.
Dr. Geeta Wani and Dr. Shilpa Mandha. We will have just these two. If the faculty permits more, then we'll go for this.
Madam, good evening, sir. What's the treatment in women with 48 years age with fibroid with adenomyosis? There is history of menorrhagia. Fibroid is around 2.5 centimeters in the left lateral wall.
Fibroid with adenomyosis, I think it is a better that she's maybe having a dual pathology. Only there is a 5 to 10% where you are having endometriosis or maybe adenomyosis with the fibroid. If it is like that, my first choice, if it is a endometrial cavity is good, I will use LNG IUCD. There is a longer effect. If the endometrial cavity is not that much good, then I will switch over to any other drug.
Can she use Mifepristone, sir?
For adenomyosis is again the problem. No, Mifepristone will not act on adenomyosis.
Very small studies for Mifepristone being of any use. You can consider giving her SERM or naloxone.
Naloxone.
Because LNG IUS is a wonderful choice, but sometimes that adenomyosis gets into the brain and the psyche of the woman. And there even little bit of hypercontractility is there in response.
Shilpa,
Okay,
if you
ma'am.
would like to speak
Yes,
up.
ma'am. Yes, ma'am. Dr. Ashish, this is Dr. Shilpa. Good evening, sir. Sir, I had a patient who is 42-year-old with posterior wall fibroid displacing the endometrial cavity, and she had menorrhagic cycles for, like 2 or 3 cycles, and she had gone into severe gross anemia. So I was, I could not place any LNG because the cavity is displaced, and she is not very keen on surgery. So can I start this Ulipristal as mentioned by you? So she's 42-year-old. Maybe the menopausal, like she's not very keen for surgery. So how do I take it from here, sir? How do I follow the patient?
I think, madam, this is the ideal case for a DGCI approved also.
Yes, sir.
So it is better to give a Ulipristal and then wait for certain time, because ideal things is a 42 perimenopausal, not fit for the surgery, not going for the surgery, severe anemia, correction
Yes.
of hemoglobin. All these things fit up into a good one case of using a Ulipristal.
So how long the effect of this, how long can I expect the shrinkage? I will follow the patient, maybe 3 or 4 years needed for her to enter into menopause. So we need to repeat it when the size increases or when her symptoms recur. So, the patient has to be under follow-up.
Ideally, the patient should be under follow-up for first month, then
Yes.
monthly for at least 3 months. See how the drug is effective.
Yes, sir.
There is the progesterone receptors, or because we don't do a estrogen progesterone receptor studies. If your drug is acting very well, you can think of a second cycle or maybe extended use of Ulipristal. If it is not working, then you have to think of a lateral go.
So if it is working only 3 months, 3 to 4 months, 3 to 4 cycles is enough for sir, for
3
her.
months is a 1 cycle, so you can give up 4 cycles.
Yes, sir.
So 1 year is gone.
Yes, sir.
Longer studies are not been available, and
Yes.
a longer follow-up of 2 years is been there, wherein they found out that a recurrence rate or regrow rate is not that much significant after the Ulipristal, but which is not true for Mifepristone.
Thank you, sir. Thank you so much.
So there are a couple of questions in the Q&A which have come up now. Just if you give me the permission. So we have Dr. Seema Nishad. She's talking about cervical fibroid with infertility, 2 centimeter size, 28 years, Ulipristal or myomectomy.
Cervical fibroid 2 centimeters is a very small fibroid. So I don't think so. Even if you do a myomectomy, will be depending upon, because if it is a cervical fibroid, you need to do a triality. You have to see whether the your catheter is growing in, because if the pregnancy is going to happen, it will be in the uterine cavity, not on the cervix. So if you are difficulty in passages of your your catheter, then and then only you think of using a Ulipristal or maybe a myomectomy. But myomectomy for 2 centimeters, I will not consider at all.
Okay, Dr. Alka Kulkarni, 50 years lady with 5 centimeter feudal fibroid, not menopausal, can be given Ulipristal?
You have to find it out whether she is a perimenopausal or menopausal, because FSH indicators will be there. If you do a FSH, it will tell you how much she is into perimenopause or menopausal, approaching the menopause. And then a 5 centimeters, see for the vascularity, see for the other markers, and then take a call whether to use a Ulipristal or not.
So again, we have a few thank yous here. Dr. Lavjeet Kumar, wonderful lecture. I'm an Ayurvedic physician. Thanks for the words.
And thank you for all the things. I really need, even if you are Ayurvedic or whenever you are homeopathic or whatever pathy you belong to, please follow the guidelines. Guidelines is good thing, that if you are using this Ulipristol, don't start right and left of using it. Do the scan, do the mapping, do the LFTs, and then use it. Because if one serious complications, you will be nowhere.
So now we come to the end of this very, very interesting lecture that we had today by Dr. Ashish Kale, and the expert comments by Dr. Girija Wagh, and of course the starting of the introductory comments by Dr. Archana Basir. So we from Jagsonpal thank all of the experts present here, and also all the attendees who have joined us today and for such a wonderful interactive session today. From my team, I have Mr. Saurabh Sharma. He would just like to say a few words.
Thank you very much, Ashish, Dr. Girija Wagh, and Dr. Archana Basir for giving a wonderful lecture, which is very useful for us. And sir, we have a Ulipristal drug that is Yuliprist, the name, and it is indicated in fibroid, and it is indicated for the long-term management of uterine fibroid. It works in fibroid, endometrium, and pituitary, and we follow the LFT guideline what you have discussed. So please do support in this drug also. And as you rightly said, it is treatment regimen for 8 cycles, and it is also found out like in some cases safe and long term for 8 treatment courses also. So we do follow the guidelines, and we have another drug in the management of uterine fibroid, Fibristone 25, which tones down the fibroid, the first generation SPR with the more progesteronic androgenic and antagonistic activity, so which reduces the symptoms and improve the outcomes, which benefits to the patients, which is endorsed by various body, and which is also a safe alternative to surgical management of uterine fibroid. And it is suggested for the pre-operative advantages, and which is available in a reduced price. So do you prescribe the Fibristone also? So both the drugs are available, and we are inviting you for the another webinar, which is going to have association with the Association of Obstetric and Gynecologists of Delhi, AOGT, for the Delhi PG forums, topic of abdomen pelvic masses. This is for postgraduates of AIIMS, New Delhi. So please to come. We hope to see you again. Thank you very much for your presence for this. Thank you. Thank you, sir.
Thank you very much. And with your permission, we'll now close the meeting.
Thanks.
Thank you so much, all the experts. Thank you. Bye-bye.
Madam.